Hi, everyone. Welcome to the Oregon Health Authority's webinar, Promoting Health Equity in School-Based Dental Sealant Programs, an Introduction to Cultural Agility, Health Literacy, and Trauma-Informed Care. I'm Karen Phillips, and I'll be presenting with Rhiannon Simon. I'm a program analyst for the Oregon Health Authority's Oral Health Unit, and I'm also an expanded practice dental hygienist who has worked as a clinician and clinical coordinator for school dental sealant programs throughout Northwest Oregon.
We didn't start the broadcast. I'm so sorry. So we're going to have to say that again, but they didn't hear any of it.
Okay.
But we have to start it.
Okay.
We started the recording, but not the broadcast.
And also, how are you going to know?
I got it down, man.
Am I?
And I want to make sure everyone can hear us before we get too far.
I can do the audio test first.
Maybe we should do that.
Sure. Hi, everyone. Welcome. This is Oregon Health Authority's Promoting Health Equity in School-Based Dental Sealant Programs, an Introduction to Cultural Agility, Health Literacy, and Trauma-Informed Care. First of all, I'd like to make sure that everyone can hear us. So we're going to do an audio test. Please raise your hand in the question or chat box to make sure that everyone can hear. Just take a few seconds for everybody to answer. So waiting for a couple of responses. Okay, it looks like almost everybody has responded. This is presented by myself, Karen Phillips, and Rhiannon Simon. I'm a program analyst for Oregon Health Authority's Oral Health Unit. I'm also an expanded practice dental hygienist who has worked as a clinician and clinical coordinator for school dental sealant programs throughout Northwest Oregon. And Rhiannon will introduce herself later in this presentation. Some housekeeping. Again, thank you for joining us today. We appreciate your time. This webinar is being recorded. Please mute your phones to avoid background noise. If you have any technical issues during the webinar, please type the issue into the chat or questions feature. Please do not put your phone on hold or take a call on the other line during the webinar. Hang up and rejoin if necessary. We also have a few interactive poll questions throughout the webinar, so please respond when the polls come up, and I'll let you know when it's time for the polls. Additionally, the webinar recording and presentation slides will be uploaded to the Oregon Health Authority's website in about a week. Oops, sorry. And here's the link, health.oregon.org/sealantcert. There will be stopping points after each topic. Questions may be asked during the pauses or at the end of the webinar. Please type your questions at any time into the questions or chat feature. This is an introduction into cultural agility, health literacy, and trauma-informed care. Again, there will be questions and answers after each section. This webinar is not a comprehensive look at the three topics. We'll provide an overview of the information, some practical examples, and additional resources. Objectives are to promote health equity in school dental sealant programs, to learn and be able to apply the values of cultural agility, health literacy, and trauma-informed care, and also to know where to access additional resources on these topics. We know that health disparities and health inequities exist in Oregon. Oregon Health Authority promotes health equity as a response to the disparities and inequities. Definitions: health disparities are measurable differences in the frequency of health conditions, health status, and outcomes between groups. Health inequities, the health disparities that are a result of the systemic and unjust distribution of the essential elements of health. That includes social determinants. Social determinants are the conditions in which people are born, grow, live, work, and age. And these circumstances are shaped by the distribution of money, power, and resources at the global, national, and local levels. It's estimated that social determinants of health account for about 40% of health outcomes. Health equity occurs when everyone in a community has the ability to achieve the highest level of health possible, regardless of who you are, how much money you have, or where you live. providing what each individual needs to reach the highest level of health, not necessarily providing the same intervention for each person. Examples would be population interventions such as fluoride versus more specific programs like dental sealant programs that are reaching students in schools that have a 40% or higher free or reduced price lunch enrollment. So why is this important? Our programs serve vulnerable and underserved populations. Promoting health equity means we remove as many barriers to access as possible. Cultural agility, health literacy, and trauma-informed care help us remove some of these barriers. This means that our most vulnerable and underserved populations can receive the care they need. Improving program and individual cultural agility also is promoted at the national level in Healthy People 2020 and at the state level. Our State Health Improvement Plan and Oregon's Strategic Plan for Oral Health both include components of cultural agility. The progress report for the Oral Health Strategic Plan notes that efforts in Oregon to improve cultural agility are not keeping pace with Oregon's rapidly changing population diversity. Also in Oregon, health professional licensing boards are collecting self-reported cultural agility continuing education data, and this data will be reported to Oregon's Office of Equity and Inclusion later this year, I think in the summer. Here's some information from the 2012 SMILES survey. According to the 2012 SMILES survey, Hispanic and Latino 6 to 9-year-olds had higher rates of cavities, untreated cavities, and rampant decay compared to white children. You can also see that Black African-American children had substantially higher rates of untreated decay compared to white children. We can see how important it is to remove barriers and provide equitable care. Our first topic is cultural agility. Cultural agility is the capacity to relate to or allow for different cultural perspectives and being flexible enough to experience a shift in your own perspective. Organizations are moving away from using the term cultural competency, which is probably more familiar, and moving toward using the terms cultural agility or cultural responsiveness. These terms acknowledge that honoring all ways of knowing is a process that requires thought, situational awareness, and action. We have a poll question. We're going to open the poll, and if you could take a few seconds to answer the question. Okay, the poll is open. Okay, a couple more seconds. Okay, everybody has voted. Thank you for participating. We're going to close the poll, and then we're going to share the responses. Okay, that's great. It looks like everybody is incorporating the cultural agility principles into their work, fairly evenly split into somewhat incorporated and well incorporated into their programs. That's great. Thank you for participating. So these are the 5 essential elements to an institution's cultural agility. We're going to go through each of these elements and provide examples. These values are noted in many cultural agility resources. These 5 elements should be manifested at every level of a program, including policymaking, administrative, and clinical practice. They should also be reflected in the attitudes, structures, and services of each school dental sealant program. The first essential element, valuing diversity, an example of valuing diversity would be demonstrating a commitment to and adopting diverse hiring practices. The second element, the capacity for cultural assessment, includes evaluating where your program and staff or individuals are in this process of adopting cultural agility. You can identify areas that are going well. You can also identify areas that may need improvement. Self-assessment also helps you understand your program and personal culture and beliefs and how they may influence your interaction with others, as well as how they may influence your own healthcare beliefs and decisions. Element 3, being conscious of cultural interaction. Know where the potential for cultural interaction can take place in your program, such as interacting with students, schools, parents, and partner organizations. Element 4, having institutional cultural knowledge. All staff should have continual training on cultural agility, and the organization and program should have standards and policies that promote and expect the principles of cultural agility. The 5th essential element, adapting to cultural diversity in service delivery, is applying the principles of cultural agility to all areas of engaging and providing services. School engagement, forms development, and awareness and respect of different beliefs regarding oral health. Expanding on training, all staff should receive cultural agility training. Program coordinators, administrators, clinicians, referral coordinators, case managers, anyone who interacts or engages with participating schools or students. This also applies to events such as back-to-school nights or school pep rallies. You can see why agility is an appropriate term to frame the action. We are interacting with many people in a variety of situations. This can help, additional training and ongoing training can help ensure that patients have positive experiences at every point of contact, every phone call, every interaction, and that staff have tools to interact respectfully with each other. It's also important to share goals and progress regarding cultural agility and seek to engage community members as support in this process. This adds additional diversity and input into your programs. It's important to understand the role of culture in oral health to improve the ability to respond to questions and concerns from participants or partners, and it also improves the ability to provide oral health services in an appropriate cultural manner. An example of a great resource to use for training is the Think Cultural Health program. Think Cultural Health is a cultural agility module designed specifically for oral health professionals. It offers specific examples for various settings, and it includes school settings. The module offers up to 6 free CE credits upon completion. It has 3 different modules. Each module has 2 credits available. Additionally, if you complete the full module, it offers a facilitator training for those who have completed the previous training. A facilitator can lead small group trainings and discussions on cultural agility. Talking a little bit about workforce diversity. Why does workforce diversity matter? Workforce should reflect the population demographics. Racially and ethnically diverse providers are more likely to work in underserved areas. In Oregon dental hygienists currently do not reflect population demographics. And a Kelly report, the workforce diversity fosters participation and compliance in healthcare recommendations. Research confirms that minority patients respond better to practitioners who share their race, ethnicity, religion, or culture. And so it improves health outcomes. I mentioned earlier that 40% of health outcomes are related to social determinants of health. Some information about Oregon's dental hygienist workforce. This is a 2014 report. This is their most current information. You can see that Oregon's hygienists are primarily female, not Hispanic or Latino, and are fairly distributed across the demographic of the working age adults. Additional information. This is a pull-out slide. They separated out ethnicity and race. So this slide is related to race, and it's comparing the Oregon's population race distribution compared to the distribution of the dental hygienists in the state. And you can see that for the Asian population, there are more Asian hygienists compared to the state population, Asian population, but the other populations are underrepresented in the hygiene workforce. So how do we improve the diversity of our workforce? We can recruit hygienists and assistants who are racially and ethnically diverse, who are bilingual, and who have experience working in culturally diverse situations. You can also promote loan forgiveness programs if the candidate is eligible. These are primarily for shortage areas or federally qualified health centers, rural areas, but it's a good thing to promote to potential candidates. Again, providing staff with ongoing training opportunities, encourage language courses or phrase books, and also bringing in culturally specific guest speakers. I mentioned Think Cultural Health as a resource, and if you complete the small group facilitator training, one can lead cultural agility discussions with colleagues, encouraging and facilitating ongoing dialogue regarding prejudice and bias. And also willingness to openly discuss topics reinforces awareness and commitment to cultural agility. The American Dental Hygienists Association in 2014 used the Think Cultural Health module training to conduct a small group training. And also cultural agility is an expectation of clinical standards for the dental hygienist. Hiring practices that support diversity. You can blind the name, address, and gender categories on the applications in order to reduce unconscious bias. Include interview questions that illustrate how the applicant has experience working with racially diverse populations. Use diverse hiring panels whenever possible so that diverse individuals are involved in the decision making. You can also seek hiring panel members from outside of your program. Also demonstrating a commitment to diverse workforces and cultural agility. Moving on to some examples of different oral health beliefs and cultural agility. Some cultures have different beliefs regarding oral health, and this can overlap with dental health literacy, socioeconomic status, and personal experiences. And to have culturally appropriate outreach, it's important to consider what communities and families understand and believe about oral health. There are many factors such as religion, ethnicity, and race that influence oral health understanding and belief. You may experience this at varying levels: parents, students, community and school administrators, and other school staff. I'm going to give you some examples, and it's important to note that healthcare beliefs are not necessarily generalizable to an entire group. Individuals within that group may have different experiences. And also, we use the term parents here and throughout the webinar, and there are often multiple barriers in accessing dental care, and we understand that children's situations are often more complex than this. Please understand parents to include guardians and caregivers as well. Some examples: some personal dental experiences may be negative. Some may not trust providers due to experiences of previous generations with healthcare. It may take more time to engage parents or students and help them feel more comfortable with the dental Sealant program or with providers. Some believe that preventive dental care isn't needed and may seek care for themselves or only seek care for themselves or their families if there is a problem. There may be parental anxiety. Parental fear is associated with not attending dental appointments. This may be, the parent may have personal experience that has created that or contributed to that fear, or they also may have fear that because they've heard about others' bad experiences. It's important to use fact sheets, include things like getting sealants doesn't hurt, on your fact sheets, and also communicate with teachers and other school staff. Use every opportunity to educate everybody about the Sealant process. Some groups may have a reliance on self-care, such as traditional medicine. Traditional medicine may be considered effective, less expensive, and it has few to no side effects. Parents may use traditional treatment for themselves, but will access dental care for their children if their child reports pain. I kind of mentioned this before. Some may believe that dental treatment is not necessarily vital for primary teeth. Some may believe that toothbrushing is to relieve bad breath as opposed to preventing caries or periodontal disease. Some may not understand the benefits of fluoride use in preventing caries, or may not understand the relationship between oral health and sweet consumption and frequent snacking. So we have a real-world example. So you've provided dental sealants for Nina, and so she's received dental sealants, and she needs to be referred to a dentist for additional care. She doesn't have a dental home, and most programs have a contact phone number for getting help for referral. So the parents call the number, and they call you to ask for help finding a dentist, and they speak Spanish at home. Some potential barriers are a language barrier, and a suggestion to use a translator, and we'll talk about translation services in just a minute. And also access to care, persuading the parents of the need for timely care. If a child has urgent care, there may be more resources available and used to get that child in for treatment sooner rather than later. And it's also important with a child that doesn't have as urgent of needs to encourage the parents to seek treatment for those cavities before they become a problem. Become a bigger problem. So translation services can be basic, such as a word-for-word translation. This may not be as effective as not all languages have words that exist in that language or that are translated easily. A translator may also be a cultural broker who provides cultural framework or context to avoid misunderstandings in the message. Translators may also act as clarifiers by using word pictures or descriptors to define a term if additional understanding is needed between parties. So depending on the message, the translator may need to have different skills in translating the message. So it's important to gain feedback, and Rhiannon will have a little bit of information about health literacy and getting feedback later in the presentation. Some cultural agility resources. So I mentioned Think Cultural Health several times. There is an overview link. So it's the first link, and it's a mini. This is what the Think Cultural Health website is about, and also gives a brief overview of the Think Cultural Health CE modules. Again, it's free online education tool with CE credits for dental hygienists, 6 credits. Additional resources, the Office of Minority Health, and the Think Cultural Health program sits under the Office of Minority Health. This is a national website. Again, a good starting point. It's important to review other resources. We've included the resources that are have quite a bit of information, so that they'll be able to direct you to trainings and other support for promoting health equity. And the Office of Equity Inclusion is Oregon's version, and again, a good starting point, and they offer trainings, resources, and support for promoting health equity. Okay, that's the conclusion of the cultural agility subject. Any questions? You can type your question into the question chat module. You can do that now, or you can do that after the completion of the webinar. I don't see any questions at this point. I'm going to turn over the presentation to Rhiannon.
Thanks, Karen.
Good morning. My name is Rhiannon Simon, and I'm a health educator at OHA with the Oral Health Unit, and I'll be presenting to you today on health literacy and trauma-informed care. Health literacy is a core component of cultural agility and communicating successfully. Health literacy is a person's capacity to access and understand health information and services to make informed, health-related decisions. 9 out of 10 adults struggle to understand and use health information when it is unfamiliar, complex, or filled with jargon. This stat illustrates how widespread the need is for easy-to-understand health information. So like before, we'll start off with a brief poll question. And as you can see on your screen, we just want to know to what extent is your program incorporating health literacy principles into its work. All right, just a few more seconds. All right, we can go ahead and close the poll and share back the results with you. So it looks like our spread is pretty similar to what we saw with cultural agility. It looks like most people are incorporating these principles at least somewhat in their work, and many of you are incorporating these principles well into your work. So that's great. Good to hear. Thanks for participating in that. So why does health literacy matter? It affects how we communicate with our parents and our programs about their child's health and treatment. Poor health literacy may impact whether a parent chooses to allow their child to participate in your program. And in particular for our topic, oral health is difficult because of the dental terminology. It's even less familiar to most individuals and more difficult to understand than healthcare terminology in general. Health literacy is also a component of Healthy People 2020, and it is one of our goals in Oregon's strategic plan for oral health as well. So there are two primary means of communication that you'll be using with parents. One version is written forms, and the other is verbal. Written forms may include permission forms, fact sheets, results forms, or email communication. Verbal interactions may include phone conversations, face-to-face interactions with children or parents. You may also have verbal interactions with school or partner staff, including counselors, office managers, and the like. It is important to hone interpersonal skills that foster empathy, engagement, and interaction to promote patient-centered health and healing. So we'll start out talking about health literacy and the forms. Forms are the primary means of communication with your parents. So the parents need to be able to read and understand them easily. Health literacy is important for all materials that are designed to reach children and parents. And when possible, forms and materials should be translated. OHA currently offers Spanish, Arabic, Hmong, Russian, Simplified Chinese, Somali, Korean, and Vietnamese. Forms should also be in plain language, and we'll discuss plain language in much more depth later on. I'd like to take a moment to make a special note about electronic forms. Some programs are transitioning to electronic forms, and all recommendations and best practices for any of the forms that we discuss during this webinar should apply to those electronic forms as well. And there may be some additional considerations for electronic forms. We want to make sure that hard copies are still available for those who may not have access to the internet, and additional instructions may be necessary depending on how the form is accessed and submitted. These instructions may need to be on the form itself or on the online portal being used. Some best practices for developing and designing your forms include identifying your purpose, audience, and key messages, arranging key messages in order of importance, writing them in plain language, adding organizational aids, and designing the format for readability. These best practices have been adapted from Maximus Center for Health Literacy, 5 Steps to Plain Language and Design for Readability. Examples of these best practices will come later, and our discussion will focus on the last 3 best practices in this list. For the most part, the first 2 items listed will be very straightforward for your Sealant program, written communications. So let's talk a little bit more about plain language. Writing in plain language means that your audience can understand easily and quickly the information that you're presenting to them. Your audience needs to be able to find what they need, understand what they find, and use what they find to meet their needs. For our purposes today, we will stick to the most practical information regarding plain language and writing forms. If anyone would like to know more about plain language and the federal requirements, please visit plainlanguage.gov. The 5 elements of plain language are friendly tone, active voice, brief paragraphs, simple sentences, and familiar words. These 5 elements have also been adapted from Maximus Center for Health Literacy. When you write in a friendly tone, you want your forms written as if they were conversational. You want them to be approachable. When using active voice, you want to make sure that the sentences and verbiage are direct. Health sciences in particular have struggled with this one because there are a lot of restrictions on what we're allowed to say, especially around causality, but we still need the information to be understandable. Whenever possible, you need to write in brief paragraphs. Your paragraphs on forms and health communications should not look like paragraphs from papers or books. They will often have fewer sentences, possibly only 1 sentence. We call this chunking, and you should use it whenever possible. Using simple sentences is pretty straightforward. A lot of times when writing, if your natural tendency is to use long sentences, you can often simply break them up and get rid of those conjunctions. And of course, use familiar words. This can mean different things for different audiences, but always err towards more familiar, simpler words. So here is a brief comparison of plain language and more technical language. This is the same information, but presented in 2 different ways. On the left is the more technical language provided by one of our hygienists on how to place the sealant, and on the right is the same information in plain language. So we've taken the same information and tried to clear it up for a non-dental professional audience. I'm going to read these briefly to you. The tooth is prepared for the dental sealant by brushing and etching. The dental sealant material is placed in the pits and fissures of the tooth and has been light cured. The sealant is examined for retention. The tooth is brushed. A tooth cleaner is used to get the tooth ready for the dental sealant. The sealant is put on the pits and grooves of the tooth. A light is used to harden the sealant. It is checked to make sure it stays on. I would also like to take this opportunity to point out that there's no one correct way to write in plain language. If you were to do a similar exercise with a few people in a room, their plain language paragraph may look quite different, but still effectively impart the same information. As you can see, the brief paragraph on the right is clearer, it uses less jargon, and a non-dental professional would be able to understand it more clearly. Before we move on, I'd like to draw your attention to the word counts and sentence counts at the bottom. The technical paragraph on the left has 35 words and 3 sentences, while the clearer, more direct plain language paragraph on the right has 47 words and 5 sentences. Now this may seem counterintuitive because often when we're clearing things up and writing for a general audience, we want fewer words, fewer sentences, and be more direct, but that's not always the case. Sometimes in order to clear a topic up, you need a little bit more. So what grade level should we be aiming towards when we write for our forms? Ideally, 5th to 8th grade level. And of course, lower is better if you can get it there. So how do you know if your forms are reaching the appropriate grade level recommendations? So there are word counts and formulas out there that a lot of people use to see if they are reaching those recommendations. But I would like to issue a word of caution. They're a great starting place, but they should never be the final stop on this process. There are limitations of the word counts and formulas because they're based on number of words and number of syllables to determine the literacy level. And it is entirely possible that you could have 2 words that have the same score in one of these formulas that are not really equivalent in reality in terms of literacy. Take, for example, the words fake and feign. They have similar meanings, and they would count the same in one of these formulas, because they are each a 1-syllable word. But the word fake is clearly more plain language and more easily understood than the word feign. So another best practice is to review the forms multiple times and field test whenever possible. And a person should always review a form for plain language, even if you've used one of those word counts or formulas. Forms should also be available in multiple languages, and plain language rules should also apply to languages other than English as well. And that is why it's important to review translations with target audiences if possible. This can often be more difficult for some languages than others, and may not always be possible, but if you have the time and you have the target audience available, it's always a good practice. It's also a good idea if you could ask schools in advance if there is a predominant language that is spoken by families in the school, that forms could be translated to ahead of time. So I'd like to make one last note on plain language, and that is compromising with legalese. Legal departments may require certain language to be included on your forms, such as privacy notices. This language should still be as accessible as possible, which is often more difficult with legal language. So I'd like to encourage you to work with your legal department or whoever is in charge of this piece for your program to make sure that this language is still as plain language as possible. All right, so we'll move on to some of the other best practices from our list. And I wanted to illustrate these with some examples. So we're going to talk about formatting forms for readability. Our example form here on the slide is from Dental 3, their school Sealant program permission slip. And it's a good example of a form that contains a lot of information, all on one page, and yet it is still formatted for readability. This form includes insurance status and the privacy notice statement. Some key takeaways from this form include the use of organizational aids, such as boxes and tables. As you can see at the top, there's a box, a darker box around the name of child, teacher and grade section that demarcates the information available and separates it from the rest of the text. They also use a chart or table to get the parent to fill in the family information, the health history, insurance information, and at the bottom they use a chart to offset the privacy notice that says please read. The fonts are clear, and the font size is large enough to be easily read. The logo is clear and well placed, and there is still some white space on the form as well. Here is another example before we move on of, and this particular form is one of our own, but it is an older version of this fact sheet. But that's not the key point here, because we're looking at the principles, the principles of designing the form and not necessarily the form content. So this form, or this fact sheet, excuse me, illustrates that some of our best practices as well. Our key messages are first, right off the bat at the top of the form, what do parents need to know about dental sealants? We have used chunking to offset the information. The bullet points contain about one sentence each, and they are short sentences. Organizational aids, such as boxes, have been used to offset certain pieces of information. There's a good use of white space on this form. It's one of the reasons why I chose the older version. This form in particular has very readable font. It is at least size 14, which is what's usually recommended to be ADA compliant. And for this audience, I should specify that when I say ADA, I mean Americans with Disabilities Act compliant, not the American Dental Association. So that this form should be still be able to be read by those who may have visual impairment. One last note on fonts, and I think most organizations are getting a lot better about this, but no one should ever use any script fonts, because those are not ADA compliant at all. So let's move on to some best practices for verbal communication. In addition to language barriers, there may be weak literacy or numeracy skills contributing to difficulties in understanding complex health information. Your first best practice is to use good listening skills. Fully concentrate, understand, and respond to the person with whom you're interacting. Another best practice is to use the principles of motivational interviewing. Motivational interviewing promotes collaboration between you and your patient rather than confrontation. It draws out your patient's ideas about change rather than imposing ideas, and emphasizing your patient's autonomy rather than emphasizing your authority. A good way to remember the skills of motivational interviewing is rule. Resist telling them what to do. Understand their motivation, listen with empathy, and empower them. Another best practice is to use the teach-back method. Teach-back method is recommended in interactions with individuals with low literacy, and it provides opportunities to assess knowledge and understanding and to fill in any gaps. So essentially, the teach-back method has you have the individual repeat back the information you just gave them in their own words, and then you can then assess whether or not they got what you were telling them and help correct any misunderstandings. And lastly, remember that all of this matters when using translation services too. We can often get caught up in the extra work that comes with using translation services to interact with someone, and then try to rush through our conversations once we have the translating service. So it's a good idea to take a minute and make sure you're still using best practices with verbal communications when using translation services. All right, so to recap, I'd like to go over some of the health literacy resources that we have pulled for you. Starting off, we have the CDC Health Literacy site. It's a very rich resource site. They have planning, evaluating, and testing tools. They can show you, they have tools regarding some of those formulas and word counts that we were discussing earlier. They have, they even have toolkits and a packet on common health terms and words that you can use instead that are more easily understood. That's a very good tool. So I would really encourage you to play around with the CDC Health Literacy website if you're looking for really easily used tools and if you want to delve a little deeper. I've also listed the plainlanguage.gov website that was mentioned earlier. That's a good starting place to look into the federal requirements, and they do have some practical tools there as well. Many of our health literacy best practices and guidance that we've provided to you in this webinar were adapted from some of the materials developed by Maximus Center for Health Literacy. And we pulled their quick plain language checklist, and the link is listed on the slide, and that's a good place to start. You can review some of your current forms and see if they meet some of these standards, or you can use the checklist while you are writing new forms. Some additional resources for health literacy include these two presentations listed. These slide decks are available at Legacy Health Literacy Conference's website. The link is provided there. This was the 2017 Health Literacy Conference from Legacy, and they had a half-day workshop on designing for readability and some practical applications for creating forms and designing. And we have pulled out those two presentations for your benefit right there at the top. And then two more resources we have listed. We have the American Association of Public Health Dentistry. This is a link to a slide deck that is about implementing health literacy specifically for oral health. The last resource we have listed is from the Frameworks Institute, and this is the link for the messaging around children's oral health literacy, and it's entitled Watch Your Mouth. So a good resource for developing messaging for children. Before we move on, does anyone have any questions regarding health literacy or the creation of forms? Just took a little bit more time. All right. Then we can move on. Our last topic is trauma-informed care, and we'll roll into this one a little differently. We'll just take a brief moment to start off with a poll question, similar to before. To what extent is your program incorporating trauma-informed care principles? So we'll just give you a few seconds to finish up. All right. So we'll share back the results with you. And this spread is a little bit more of what I expected for this topic. It seems that most of you are a little less involved or informed about trauma-informed care principles, and it's kind of a newer topic than the other two, and so that kind of reflects what I expected. All right. So before we talk about trauma-informed care, let's get a grasp of how common trauma or adverse life events are. So an estimated 60% of adults in the U.S. experience an adverse life event or trauma at least once in their lives. 26% of children in the U.S. will witness or experience a traumatic event before they turn 4. 4 of every 10 children in America say they have experienced a physical assault during the past year. More than 60% of youth aged 17 and younger have been exposed to crime, violence, and abuse, either directly or indirectly. So our key takeaway message is that your staff, as well as the children receiving dental sealants from you, may have experienced trauma. What trauma looks like can vary. Different people react to and express trauma in different ways. Trauma victims may suffer from anxiety. They may have difficulty trusting others. They may develop coping methods that evolve into health risk behaviors, such as eating unhealthy foods or overeating, smoking, and abusing drugs and alcohol. And they may exhibit psychological reactions, such as the triggering of traumatic memories when touched by a dental hygienist, when lying down in a dental chair, or when having items in their mouths. As you can imagine, receiving oral health care can be a pretty vulnerable experience and may re-trigger some previous trauma. So, how can an organization respond effectively to trauma? A program, organization, or system that is trauma-informed realizes the widespread impact of trauma and understands potential paths for recovery, recognizes the signs and symptoms of trauma in clients, families, staff, and others involved with their system, and responds by fully integrating knowledge about trauma into policies, procedures, and practices, and seeks to actively resist re-traumatization. So why is trauma-informed care important? Trauma is pervasive. Trauma's impact is broad, deep, and life-shaping. Trauma differentially affects the more vulnerable. And trauma affects how people approach services, including dental. And the service system itself has often been activating or re-traumatizing. Examples of this include welfare systems, assistance programs, and healthcare. All right, so I'd like to take a moment to walk you through this chart a little bit. This is from Trauma Informed Oregon, and they will be listed later as a resource, and a very good one at that. So this is a chart that shows how trauma-informed care can respond effectively to trauma and restore a sense of safety and power and worth for an individual. Agencies should make a commitment to trauma awareness and understand the impact of historical trauma. And agencies can demonstrate trauma-informed care with policies, procedures, and practices that create safe context through trustworthiness and choice, restore power through choice and empowerment, and promote self-worth through collaboration. So let's talk about some best practices for adopting trauma-informed care principles. We can incorporate basic knowledge of trauma into your required annual clinical training. Staff should be aware of typical reactions trauma survivors may have and be knowledgeable that a student may be nervous because the setting has the potential of replicating past trauma. And when we're talking about typical reactions, we do need to remember that everyone reacts a little differently and responds a little differently. And just because someone has a negative reaction doesn't necessarily mean it's replicating past trauma, but we do need to be aware that it's possible. And typical reactions may include fear, nervousness, or an inability to cooperate with the hygienist. And it's always a good, a best practice to explain the dental sealants procedure before you begin. Some more best practices include establishing a signal with the student so they can notify you when it's too difficult for them to continue. You might be able to do that whenever you explain the dental sealant procedure. Having a soft object that a student can hold or squeeze that may be distracting or calming. And in terms of staff, allowing staff to take time for self-care, both for their own wellness and their ability to provide high-quality services. It's important to note here that self-care may look different for everyone. Some may need quiet time to recharge, and others may need activities and social interaction, which may not be what is currently seen as being typical for self-care. So that was a brief introduction to trauma-informed care and some best practices that you can incorporate into your dental sealant programs. We have here listed some resources for more information on trauma-informed care. We have Trauma-Informed Oregon, in particular, has some good materials and may be available for training if your organization is interested. We have the Center for Healthcare Strategies Advancing Trauma-Informed Care, and the Substance Abuse and Mental Health Services Administration are good places for more information. So at this point, I'd like to pause for questions regarding the trauma-informed care section. So we have a question that came through, but I'm not sure that we can understand it. I think maybe your question got cut off. So if you typed a question, could you maybe try to resend it? Okay, so if anyone has any questions about any of the three topics, we're happy to field those right now as well. Okay, so we have a question that says, does OHA keep examples of forms from around the state?
We do, is part of the verification site visit. We are looking at your forms to make sure that you guys meet your certification requirements. Now, we haven't gotten permission from all the programs to share that, but that's something that we can certainly work on and kind of do a poll out there with programs if they're willing to share their forms. We can certainly do that by email and get permission before we do that.
Great. Do we have any other questions regarding any of the three topics that we covered? We've built in plenty of time for questions, so. All right. Well, our contact information is in the slides as well. So you can always reach out to us directly if you have any other questions. Oh, it looks like maybe we got another one. Okay, so we have a comment. They just wanted to let other programs know that interpreter services are a covered service through OHP, and most clinics eat the cost. So thank you for that. All right. So if we don't have any other questions, I'd like to thank everyone for participating today. And so please reach out to us if you have any additional questions. Feel free to email us. And we will be sending out a brief post-webinar SurveyMonkey after the webinar today to get some feedback about how we can improve this webinar in the future.
Thank
So
you.